to everyone. It's a pleasure for us to be here again this year at the TCTAP 2015 and for this 20 years anniversary of the meeting. And I have the pleasure of being here with my very good friends and colleagues, Eberhard Grube, Susheel Kodali and Corrado Tamburino to discuss about the state of the art and the future of transcatheter aortic valve replacement. So we have been discussing this year after year, and we are making progress. So where are we today? And we can say that we observe a considerable worldwide expansion of these technologies with a very high potential. Today, most of our knowledge has been acquired with the use of two different type of valves, the balloon expandable Edwards valve and the Medtronic self-expanding core valve, which are implanted in equal part in Europe. But it's a very, very large number of patients performed over the last 10 years, about 200,000 procedures done, and in, I would say, more than 700 centers in the world, with a 40% annual growth. So this procedure is extremely well accepted. So what are the issues that we would like to discuss today? So the current guidelines, we have some limitations to do this procedure. The results of some clinical trials that have been selected by Dr. Park, improving the clinical outcomes, expanding the indications, so where are we going, and what are the new generation devices. So first of all, we have to understand that we cannot implant a valve percutaneously to any patient. We have to respect some guidelines. We have the European guidelines and the US guidelines. More or less, they say the same. So we can do a percutaneous valve implantation for aortic stenosis in patients who are at prohibited risk for surgery. We can also do this procedure in patients who are at high risk for surgery, according to the opinion of the heart valve team, which is mandatory in each institution. And today, I must say that we have a trend to observe that there is a trend to include some patients who are at lower risk than those regularly accepted by the guidelines. And this is something that we will probably discuss a little later. So we had got very important information for a recent presentation in international meetings, like, for example, this 5-year outcome of the Partner 1 trial. If you know, you remember that the Partner trial was done in the United States starting in 2009 and including more than 3,000 patients. And so the patients were divided into two groups according to the possibility of having the valve replaced surgically or only because they were at high risk for surgery. And in the high risk group that you can see here, surgery and TAVR were compared. And so we got progressively the results at 12 months and then 2 years, 3 years, and now we are reaching 5 years. And as you can see on the curve here, clearly there is no difference in mortality rate between the two intervention, surgery, and TAVR. So this is very good news. Now, we also got at the last ACC meeting in the United States the 2 years outcomes of the core valve trial, where surgery and the core valve implantations were compared in high-risk patients. I think that the definition of high risk was a STS score above 7%, if I remember. So we had last year, we presented last year results at 1 year. Now we have the results at 2 years. And something very important is that for the first time, a benefit of percutaneous transcatheter valve was evidenced in comparison to surgery. So you see this difference in mortality rate at 2 years, and this is also something extremely encouraging and promising. We had also last year the results of the only randomized comparison of the two devices, balloon expandable and self-expanding. I would say more or less that the results are satisfactory and quite comparable, with, however, maybe a little more aortic regurgitation with the core valve and the the Davis success rate, which was a little less with the core valve in this choice trial done in Germany, and with the first generation core valve. So I think that when we want to do this kind of randomized comparison between the two devices, it would be extremely important to start again a new study with the new devices. We have really changed the world of TAVI, the Sapien 3 valve, balloon expandable, and the Evolute core valve, which is a new device of Medtronic. So the good thing and the most important message is that we are going to a fantastic improvement of the mortality with this percutaneous procedure. You can see here the progressive decrease of the mortality rate at 1 year, at 30 days with time, and starting with the first in human and finishing with Sapien 3. Today we have also the result with the Evolute, where the mortality rate is actually 0%. So there is no doubt that, and this is the most important message, we are decreasing the mortality rate at 30 days. And this let us think about the possibility of moving progressively to lower risk patients and younger patients. We have also changed the way of implanting the valve transfemoral, and this is certainly a big progress, where the minimalist approach is coming up and growing very rapidly in Europe and United States. So it means that we have moved to a relatively complex procedure requiring a number of people in the room, general anesthesia, transesophageal echo, to the so-called minimalist approach, where, as you can see on the right, in Atlanta, for example, in this slide, only 2 people are required to implant the valve, and there is no anesthesiologist and no transesophageal echo. So things are going extremely well, and it has been clearly shown that doing the minimalist approach or standard approach, the results are similar, and the outcome is the same. Also, and this is extremely important, especially in this part of the world, the cost definitely decreased by reduction of the resources and the hospital stay. So there is a trend to think that we will move quite soon to lower risk patients, and of course we are expecting a lot the results of the evidence-based trial that you can see here, the CERTAVI and the Partner 2 trial. CERTAVI with a core valve, Partner 2 with the Edwards balloon expandable valve, and the XT and the S3, Sapien 3, and so this is something that we expect a lot, because if this shows that the risk of surgery, the mortality rate after surgery or after TAVR is relatively similar in this category of patients, it will have fantastic consequences on the future of this procedure. People are interested in the results of TAVR in a bicuspid aortic valve, and especially I think this is a concern in China. So there is a study which has been recently published in 2014 comparing 2 devices, the core valve and Sapien, for the bicuspid valve. In summary, it shows that you can implant the valve in bicuspid valve. It's not a contraindications. I would say myself that probably very calcific bicuspid aortic valve that you can meet mainly in younger patients remains the best indications for surgery. Now there is a new field which is valve-in-valve. It means the use of the transcatheter valve for treating a degenerated surgical bioprosthesis. This is not a niche. This is something which is progressively increasing. We have learned a lot about this, and we know that finally implanting a transcatheter valve to treat a failed bioprosthesis gives excellent results on the short and mid-term. The results are a little better with a core valve in case of small size prosthesis, even though now with a small size balloon expandable valve, 20 millimeter, we can probably reach the same kind of result. But this is very well accepted, and not only to treat degenerated surgical bioprosthesis, but of course to treat any problem related to a transcatheter valve implantation. So as you can see on these slides, we have to make a choice today between a number of different devices. Actually, 16 different devices are under investigations, and the physicians will probably have some difficulties to make the selection. Probably the experience of the team is absolutely important, but all these devices have been created to decrease the complication rate, and this is also something extraordinarily important if we want to move to lower risk patients. So this is what we can say to summarize the situation of transcatheter aortic valve implantation in 2015. So now we can have a free discussion about each of these different items, and I will maybe start by you. Dr. Tamburino, maybe can we try to select to go step by step in different questions? So concerning the indications in Italy.
Very briefly, so I will express my personal opinion about the current guideline and real-world practice. So real-world is fully different than currently adopted guidelines. So guideline is an indication. The true world is a different way to proceed on. In the real world, we are treating all kinds of patients. So I would say that an 80-year-old patient, even with a STS score by 1, is treated in many centers by TAVI with excellent results. So I would say that there is a clear widening of the indication, expansion of the indications. And I hope that the new guidelines will be changing once the long-term results of the partner 1 and hopefully the partner 2 will be published. Second, I think that the expansion of the indication to other kind of diseases such as bicuspid or valve-in-valve is another point. We know that it's possible to do that because we did that. So we have done, and in many centers, many valves have biological prosthesis have been treated by TAVI and different models of TAVI, and as well as the bicuspid valve, although is a borderline indication in some cases, as you said. But frankly, I would say that the new generation of valve will change and will improve the data that we know already, because the aortic regurgitation, which was a problem because it has an impact on the mortality, is almost null with the new model of valves. So, and also the cerebral embolism is reduced to 1%, so is a relative problem. I would say that for widening the indication to younger population, the only problem we have to solve is the pacemaker indication, because pacemaker leads have a duration. So in a 65-year-old man or putting a valve with a risk of a pacemaker indication could be controversial.
So I just would like to say that I totally agree with you when you say that there is a difference between the guidelines and the real practice. So, for example, and you gave this fantastic example of a patient with more than 80 years of age with a low risk, and today it's extremely difficult for us to explain to the patient that he has to go to surgery just because of the guidelines. However, in some places, like in France, for example, if you are not respecting the guidelines, the valve is not reimbursed. So we have to pay attention to that, and this is why I'm expecting so much to have this modification of guidelines, because in elderly patients there is absolutely no doubt that this is the technique that you must offer to the patients.
In Germany, they do that. Because in Germany, the rate of valve implantation is 3 times higher than Italy, which is the second European country.
Yes, absolutely. But you are talking about Germany, so Eberhard, what do you think?
Who's the gatekeeper, right? I mean, you're talking about these guidelines, but you went through 10 years of data from where you started very rapidly, but the guidelines have only been changed once during that time period. And that it's a two-way indication as an alternative to surgery in high-risk patients, and that was done before the core valve data. That's done before a lot of this data. So, the real world has to practice differently. But the problem is in the U.S., same as what you mentioned, Medicare is the gatekeeper, so you won't be reimbursed. But they leave a little wiggle room. So as long as the surgeons are engaged and the surgeons are willing to write the patient as high risk, an 85-year-old re-op has an STS score of 4. But a lot of surgeons at this point have agreed, at least in our institution and many institutions, that that patient is high risk.
Yes,
Even though they would have operated on that patient, the patient's not high risk, but to fit with the guidelines and get reimbursed, they said the patient's high risk.
I think we should definitely include the patients in the heart team, to take the decision. And the patients have definitely to be really advised of the advantages and disadvantages of the two procedures, and then make their choice. But the patients must be included in the
No one is right
in
now.
the heart
Right now,
team.
they're not at all. They're the only ones that are not a part of the heart team decision, right?
So, Eberhard, what do you think?
I mean, it's not only in TAVR, it's been with PCIs in the past, the guidelines. The guidelines are a recommendation. It's a workup of committees looking at the randomized trials, and then according to the trials, they put the different recommendations into place. The Europeans are right now, I think, 4 years behind. 2012 was the last revisit of those guidelines. So they're not up to date. And I think what's important, and I think this is being practiced like in the United States, if we have the surgeons on board, and that is common practice in Germany right now, if we have the surgeons on board and they agree to the TAVR procedure, we will not have any problems, regardless of guidelines, with reimbursement. If the surgeons are not in the boat, then you have a serious problem. And then, not the guidelines do help you, nor the patient statement, nor our statements. The surgeons has to be on board. And I think this is one very, very important aspect, which people might forget, particularly in view of the minimalization of the procedure, that people say, well, we really don't need the surgeons anymore. It is not about the complications. We know that the complications are low. We know that we can handle them for the most part anyway. And for that matter, I don't think we need surgery. What we do need surgeons for is for the discussion of the patient and for the assessment of the risk. And I think the risk factors, talking about high risk, low risk, what exactly is being defined as high risk, low risk? We went to the STS score, the Euro score. This is all floating. And as long as the heart team decides this patient is a good candidate for surgery, he will be done, for surgery or for TAVR, he will be done accordingly and grouped into the treatment strategies. And I think this is an important aspect for us that we have to follow. We cannot leapfrog and say, well, we're doing so well, why don't we just leave the surgeons out of the boat and we keep going? Because I think then we go into the wrong direction.
How do you get the surgeons on board? I mean, there's a lot of differences. I mean, the U.S., it's tight. Reimbursement, half the reimbursement goes to half the physician fee goes to the surgeon, half goes to the interventionalist. So that it keeps them financially involved.
They don't care.
But you see a lot of variability across the world, Japan or even in Europe. How do you engage the surgeons? Is it only through financial means? How are we going to?
No, it's if I can say, in France, it's absolutely not financial need. We have a very good relationship with the surgeons, at least in my place and as in many places. So we discuss the indications. So the surgeons are concerned by the indications. Now, today, the surgeons are no more concerned by the procedures, clearly. So as I explained, with the minimalist approach, the surgeons are not in the room. They are aware. They are not on standby. They are aware that we are doing a procedure, but I must say that we don't need them very much, and almost never. The surgeon should be more and more concerned by TAVI for a very good reason, is that 90% of the procedures can be done transfemoral.
Yeah.
So this is a new era, and especially with the development of its new devices, ultra-low profile devices like the Evolut or the Sapien 3, we have only 10% of patients that will have the valve implanted with surgical approaches. So the surgeons must be involved in doing the procedure themselves. So this is something new, that the surgeons, if they don't want to lose the market, especially if we are moving down to lower risk patients, younger patients, not to say all patients, as Martin Leon said this morning, the all patient TAVR is in the pipeline within some while, 2, 3, 4 years. The surgeons has to be trained to doing this procedure, and we will keep sharing the market, if I can say, with the surgeons doing the same thing, and probably 90% transfemoral. So this is the way it will work in the coming years.
Going back to the indication and to the guidelines, I would like to make some comments. So the studies such as the US high-risk patient with the core valve and the partner one were done in comparing new technology with new operators, with an old established technology. And the new technology was with old devices, which are not anymore used in Europe. So you started a partner study with a 23 French catheter, now is 14 French. So all the vascular complications are gone, as well as the cerebrovascular accidents, because you are a less bulky device. So I think that in the future, TAVI will be the main procedure for aortic stenosis patient, because the continuous success of partner has demonstrated a dramatic reduction in complications. It is true or not?
No,
Remember,
it's very true. I mean, the partner trial, the 5-year data is from 2007 to 2009. Of the 20-some sites, only 3 had done TAVR before. And the majority of the trial was enrolled with the Retroflex 1 device that didn't have a nose cone for crossing. So you're talking, like you said, the data is sort of historic. I mean, the durability data is relevant. But the question is, now you have SAPIEN 3, you have Evolut data. The indications, right? In SAPIEN 3, intermediate risk group, it was still 82 years old, right? You have 1% mortality, 1% major stroke. How rapidly that information is believed, adopted, will dictate how rapidly this technology is evolved. Because you could say very easily, anyone above 80, as you said in Italy, anyone over 80 should get a transcatheter valve, especially with the data you have now, where you're getting to 1-2% mortalities and 1-2% major stroke. But that's not the reality as the guidelines. So that's not the reality of how it's practiced by many people. And the issue that the surgeons will often hold on to, which is relevant, but is it as relevant in 80-year-old, is the durability. And does durability of a transcatheter valve have to be the same as the surgical valve?
it's the same.
Does it have to be the same?
Well, this was the next question that I had to discuss, the durability. Because now, if we think about moving to younger patients, the durability is essential. But I am not very worried. I can tell you I'm not very worried. Even though the degeneration of the valve in younger patients may be accelerated in comparison to the older one, we know today that the degenerations, failure of procedure is extremely rare. For example, in our experience, we have now reached almost 1,000 patients done, and we had a single case of degeneration of the valve at 6 years. We have, I thought he was the world champion, but probably he has to share this world championship with some patients from the John Webb, but we have patients now who crossed 9 years of follow-up without any problem on the valve, not a single piece of calcium, not any thickening of the valve, no increase in aortic regurgitation. When you bring this kind of data with the first generation valve, which was the SAPIEN valve, 9 years of follow-up, it's absolutely extraordinary. So my personal feeling is that we will finish by having the same kind of result and the bioprosthetic valve offer today to the patients, and we can put the 10 years, as the rule in the future, even for younger patients. So now, if you implant a valve in young patients with a potentially 10 years of duration, then you can, of course, think about placing a second valve inside the first one, and you will make the follow-up 10 years longer. And after that, we don't know. So I am very optimistic about the duration of this valve. What do you think, Eberhard, about the duration of the valve? Are you concerned about that?
No, I absolutely follow you. I think it's much better than expected. I think it's being still reported when we have degeneration of the valve, and I'm not expecting anything. The only concern, and you mentioned that, even though it's the next topic here, but given the fact that we only have 7 minutes left, I think if on the aortic stenosis front, I think the book's written, and now it's a question of acceptance and guidelines and everything. But I think the data is clear, and they're speaking a very clear message. However, if we go into the younger, and you said that, Alain, before, when we go into the younger population, younger patients, 60s, we will meet more bicuspid valves, and that's a very, very important issue, because then I believe with the valves being squeezed, being deformed, not looking so nice as we are used to, then we might be a little bit more
Well, I think
concerned.
this should be the one of the remaining indications of surgery in the
Absolutely. I
future, even
couldn't
for
agree
younger
more with you.
patients. Yeah.
Unless we have valves that when we
Are
follow.
designed for it.
Yes.
Yeah.
We have just 5 minutes left, and I think maybe would you like to give your opinion about the new devices coming? I think we are today, in 2015, we are entering a new world. We can forget a little about the results obtained with the first generation device. This is a new thing, less complications, low profile valve and so on. Do you have any feeling about how could a physician select the best valve among the 6 or 7 that are today on the market?
I would say this in 2 minutes, and I have to be a little
You
bit
have
more.
exactly 2 minutes.
Yeah, 2 minutes, and I think it is going to be resolved on its own way. It's not like in the stent era. Supporting a valve is financially extremely expensive. And my prediction would be that now we have, I don't know, 16, maybe 20, on the screen. For the most part, 17 will disappear, and for the good and for the worst, I think only a few will survive, and personally, rightfully so, because it's just not. It's much more complex than maybe many believe it is, and I don't think. I think many of those valves that are being tested right now will disappear before they see the light of the day. And therefore, the question of how many valves, I agree with you, 2 valves is probably enough.
Yeah.
Whoever.
And why should I change a valve for another valve?
Yeah.
Why?
Unless it's for price.
Right.
Unless
And
for price.
that will
Similar
dictate
result.
it. Yeah,
So
absolutely.
actually, we are following the history of stents.
Yeah, exactly. It's going to keep coming down and down. No, but I think, but the question that you raised is, are there patient-specific characteristics that are better suited for one valve or another? And everyone has their own sort of feelings of what they would do in a certain anatomy or not. But I think there's several groups that are working on modeling based on CT. There have been some reports presented. I could see in 5 years very quickly that you'll get the CT. It will be analyzed by finite element analysis. You'll model what each of the valves looks like.
Yeah.
What are the
The
risks?
best one for the
best
patient.
one, and you'll do patient
Individualized.
specific. I mean, and I think that's the direction it's going to go. But I don't think you're going to have 16. I think you'll have 3 to choose from probably.
Yeah.
So finally, we have ultra-low profile devices. We have solved more or less the problem of paravalvular leak. There is no problem with the mitral valve. The coronary arteries are not occluded. We have less and less pacemakers. So everything is going in the right direction. So we have just 2 minutes to say, how do you see the future?
I can tell you what I see in the future. No, because I try to project in the future. I see what we are trying to do, where we start to do. TAVI will be a PCI-like procedure in most of the centers. And so this is the way to proceed on, because you don't spend money in keeping the patient in ICU. And remember that elderly patients take 1 week to recover, 1 day of hospitalization. So the less the patient stays in hospital, the better is for the patient. So I think that the next future is TAVI will be a PCI-like procedure.
And you, Susheel?
I think it's gone that way, but I think my concern is I'm always the worrier. And what is the stent thrombosis of TAVI? What are we going to see down the road? And we've seen, the Portico trial was stopped because of thrombus formation on the leaflets. Is there something? Are we going to see accelerated left main disease because you have flow eddies and disturbances, and you get accelerated atherosclerosis? 6-8 years. I don't know.
We didn't see so far.
We didn't see.
We didn't see so far.
But we don't have a lot of
We
patients
didn't
out.
see so far.
We don't have a
10
lot of
years.
patients. Yeah, we don't have a lot of patients beyond 5 years, right?
200,000.
So I mean, I think we have to be continue. I
Yes,
think it's exciting,
absolutely,
but I think we
sure.
got to be.
We have to be cautious,
Yes.
and we have to follow.
It would
And you.
yet be the first technology that would go through without any complications.
Yes, exactly.
So I think it's only a matter of time, but I think we all see a bright future for this, as you predicted at the very beginning. You are an optimist. You
Yes,
choose
I
to
am
be an
an
optimist. Me too. Susheel is skeptical,
I'm optimistic.
I just worry.
and Corrado is an optimist, double 3.
So,
So it's European versus the
and
US.
finally, 13 years after the first in-man case, everything's fine and the future is promising. Yes?
Yeah.
This is the last word. Thank you very much to
Thank
all of
you
you.
very
Thank
much.
you.
Thank
Thank
you.
you.